Welcome to Coliseum Cardiac Perspectives, a monthly program focusing on the health and medical care of your heart. I'm Nancy White with Coliseum Health System. Thank you for joining us.
And I'm Roger Culver with Coliseum. Today we're talking about heart or cardiac catheterization, a medical procedure commonly used to diagnose and treat certain heart conditions. While death rates from heart disease have declined over recent years, it remains the leading killer for both men and women among all racial and ethnic groups in America. In fact, nearly 1 million Americans die of heart disease each year.
But there's good news. Advances in medical technology allow us to diagnose heart disease earlier than ever, as well as to treat it with minimally invasive techniques. Cardiac catheterization is one of those medical procedures. Doctors put a long, thin, flexible tube called a catheter into a blood vessel and they thread it to your heart. Now, through this catheter, they can perform diagnostic tests and treatments on your heart. You're awake during the procedure, it causes little to no pain, and rarely does it cause serious complications.
Joining us to explain the sophisticated procedure and the diseases it treats is cardiologist Maria Bartlett, who is also the medical director for our cath lab at Coliseum Regional Cardiac Center. Dr. Bartlett, thank you for taking time from your busy practice to being with us today. Before we get started, how about telling us a little bit about your practice and your experience and your training?
Well, Roger, I actually grew up in Middle Georgia, went to Mercer undergrad and trained for medical at the Medical College of Georgia in Augusta. I then moved to Ohio and did my internal medicine and my cardiology there. In 1988, my husband and I moved back to Macon to set down some deep roots, and I've been practicing here ever since. My practice is located at Heart of Georgia Cardiology. I have a medical complex there with a total of 4 partners and have been there for at least 12 years at that one location.
Great, great. Good to have you. Now tell us, who needs cardiac catheterization?
Catheterization is usually a test that we use to diagnose someone that the cardiologist feels may have some blocked arteries, or if we're concerned about the heart muscle and perhaps some heart valves, we generally recommend that they undergo a catheterization.
Is there anybody that's not a candidate that would be contraindicated for?
Catheterization can be done on a wide variety of patients. The only patient that really would not be a candidate would be someone that's uncooperative. It does require that you be cooperative and able to lay on your back for a period of time with some sedation, and also be able to cooperate post-procedure, holding still for generally a couple hours so we don't have bleeding complications.
How has it reduced cardiovascular surgeries?
Well, cardiology in the past 10 years has really been revolutionized by the use of stents, and we have increasingly gotten more aggressive about arteries that we fix with balloons and stents, and arteries that we never would have considered fixing 10 years ago are now routinely stented, and has cut down significantly the need to go to open heart surgery.
Are many done on an emergency basis versus routine, or?
We prefer to do them routinely, but we do have frequent emergencies, and usually that's the patient that comes in with an acute heart attack that we emergently take to the cath lab and want to try to stop the heart attack, open the artery, and limit the damage.
In that regard, have heart caths reduced mortality from heart disease?
Very much so. Certainly we've reduced mortality in the heart attack patient, but there's another obvious subsets of patients that we have been able to affect mortality with what we call revascularization, generally with stents.
What are the risks involved?
The risks are small. It's become a very safe procedure in 2008. We do have the risk of major complications, generally less than 1%. You can get some bleeding at the site. You can get some puncture through the artery that may not seal with the devices that we have. You can occasionally dislodge a clot and rarely have a stroke. You have the risk of perhaps a rhythm disturbance and rarely a heart attack with death.
What are some of the more sophisticated diagnostics that it does, beyond putting in the stents and so forth?
Well, it's certainly the standard of care is felt to be the gold standard for valvular disease and diseases of the aorta. But I have to say that the most common utilization is for the coronary disease diagnosis and treatment.
Now in the cardiac cath lab, that is centralized to the heart area only.
correct. We do occasionally look at some of the peripheral vessels, but generally that is the focus is the heart and its structures.
Tell me how often you go in the femoral versus the radial artery or any other.
I have to say that the most common approach is femoral. It's a big artery, it's easier access, it's technically easier. We're doing more and more radial cases. Sometimes the femoral artery is not accessible related to blockage or previous surgeries, and the arm or the radial has to be utilized.
Dr. Bartlett, tell us the difference between a bare metal stent and a medicated stent, if you would.
The bare metal stents have been available for, I would say, at least 10 years, and they've gotten progressively more and more deliverable and refined to where we can put those stents in a lot of places that we couldn't have even begun to put them 5 years ago. So the deliverability of these stents is wonderful, but we still had problems with what we called restenosis, blockages coming back. And the bare metal stents have now been coated with medication, and the medication really has dramatically reduced that restenosis in these arteries so that it's almost non-existent. Generally, it's in the 3% range.
Dr. Bartlett, explain to us how Plavix comes into play post-op from a cardiac catheterization.
Well, Plavix is very, very important whenever we place a stent, and it's usually the physician's judgment on whether they use the bare metal stent or the drug-eluting stent. The drug-eluting stents, because of the drug that is coated on the stent, takes much longer to heal the artery and endothelialize, which is basically the normal covering of the artery forming inside the stent. The Plavix helps that stent stay open until that process has occurred. And with a bare metal stent, usually you have to have a minimum of a month of Plavix. Depending on the type of drug-eluting stent, you need it for a minimum of 3 to 6 months. And we are now recommending Plavix after a stent for a total of a minimum of a year.
Our spotlight today on the Cardiac Cath Lab is really one in a series on the entire Coliseum Regional Cardiac Center. So could you sort of explain or accentuate to our viewers the importance of having the open heart surgery service in addition to a cath lab and how they work together in terms of a cardiac center?
It is very important to a cardiologist to have appropriate backup for safety. We do a lot of aggressive procedures. We take a lot of chances, which are reasonable chances, but certainly we never forget the possibility of something going wrong and getting into an emergency. So the surgeons are always available for backup. But also there are limitations to what we can do. There's the patient with severe disease or areas of very high risk for us to try to fix with a balloon or stent, and in those patients it's very important to have our surgical colleagues available to revascularize with surgery, which is frequently a more permanent solution than the stenting alone.
So they may go immediately from the cath lab to open heart surgery.
Correct.
And
that can happen.
Right.
Happens rarely. We usually like to maintain stability, but it happens.
Right. And it's comforting to know that it's all there in one location.
Absolutely.
Well, thank you so much for sharing your time.